Good evening, everyone. I'm Yashasvi, postdoctoral trainee at NRS Medical College, Kolkata. On behalf of Endocrine Society of Bengal, I invite you all to today's 4E webinar. The topic for today's webinar is anti-Mullerian hormone, a topic which is important to us PDTs academically and also clinically to all practicing endocrinologists. Uh, Today's session will be chaired by Dr. Pranab Kumar Sahana, sir, who is currently working as a professor in the Department of Endocrinology at IPGMER Hospital, Kolkata, and is an alumnus of Medical College Bengal and IPGMER Kolkata. He is postdoctoral faculty and examiner of DM Endocrinology course of WBUHS and also academic coordinator of DTCT course. He's a reviewer of many national and international journals and is also a principal investigator of several multi-center clinical trials. He's a life member of many national and international societies and has more than 50 research publications in various national and international journals. Thank you so much, sir, for being the chairperson for the session. The speaker for today's session is Dr. KVS Harikumar, sir, who is an consultant endocrinologist at Magna Clinics and Fernandez Hospital, Hyderabad. He has received the Shakuntala Amir Chand and M.N. Sen Oration Awards from ICMR New Delhi, and has also been the recipient of Dr. J.S. Bajaj Oration Award from National Academy of Medical Sciences, New Delhi. He's also received the Dr. A.R. Seth Gold Medal from Endocrine Society of India at ESICON, and has been the Thyroid Rising Star Oration from, and also done the Thyroid Rising Star Oration from Indian Thyroid Society. He received the Young Investigator Award from RSSDI, API, and UPDA, and has several publications in peer-reviewed journals. Thank you so much, sir. I now request Dr. Pranab Kumar Sahana, sir, to please take over the session and introduce the topic. Over to you, sir.
Thank you, Yashasvi, for your kind words regarding my introduction. Today, our topic is anti-Mullerian hormone. Now, we all know that anti-Mullerian hormone is a hormone which is principally responsible for regression of Mullerian ducts of male fetus during the differentiation stage. But anti-Mullerian hormone also helps in the development of gonads, both the testes and ovary. It is secreted by Sertoli cells in case of male testes from the testes, and in case of female, it is secreted from the granulosa cells of the ovary. So AMH acts as a screening tool for variety of endocrine disorders like PCOS, like DSD, and also it is an important tool in the evaluation of infertility. Without much ado, I just want to hand over to Dr. KVS Harikumar. He is an excellent speaker. Please listen to Dr. Harikumar. Please start your deliveration, Dr. Harikumar, please.
Thank you, sir, for the kind words. And thanks to the Team Endocrine Society of Bengal for inviting me. As rightly mentioned by the chairperson, sir, it is like a hormone which has multiple phases to it. It is not a single phase or single place where it is going to work. So in the next 30-35 minutes, I shall be discussing about various aspects of AMH in the endocrine practice and how we have evolved. And before I start, I wanted to show with this cartoon. I'm sure most of us who have interest in mythology will understand what the Lord Krishna is trying to show. That when, mother scolds that you are eating all rubbish, so he just opens the mouth and then you get to see the whole world there. So what actually is something like AMH is going to be showing us most of the things what we have never thought about or what we didn't anticipate that it has some role in it. So I shall cover the topic in the following headings. The basic physiology in both males and females, whereas it started with males and now it is doing more number of studies in the females. The role of AMH in the reproductive endocrinology. AMH specifically in males, leave alone the initial portion of physiology, but what it does thereafter postnatally. Pediatric endocrinology and neuroendocrinology, there's a lot of research coming up about the role of AMH and some recent advances regarding the PCOS and AMH analogues. The man behind all this is Professor Alfred Jost. He is actually the father of sexual differentiation. a very elegant experiments. Actually, if you look at, since I'm going a bit in detail because I was told that this is for the residents, so it is like, it is always good to know how people have started looking at the topic and then evaluated and then reached to a meaningful conclusion. When he wanted to identify how the gonads differentiate into males and females, in default, if the ovaries were removed, the rabbit was developing as a female, and even in the male fetus, if testes were removed, it was default coming into female. Now what he did was, he thought, okay, now testosterone is the one which is a male hormone, so let us give testosterone. He gave testosterone. So to his surprise, the Wolffian ducts developed, but Mullerians did not go back. So he said, okay, there is something else which is not doing this job. It is not only the testosterone. Till the time, actually, the whole world was thinking only testosterone is the one which is responsible for the development of Wolffian and regression of Mullerian, which was, he was the first one who thought, no, it is not so. And then when he grafted the testis, actually a testicular tissue, this led to regression of Mullerian structures. So he didn't know what it was, but he just said that it's a Mullerian inhibiting substance, the erstwhile name of the AMH. So that is how things were evolved. And then, I mean, the student of his, I will end up with her photo and other things. The student of his is the one who actually led maximum research in the AMH field. And this was the paper published in 1947 with our Independence Day. This is the story of AMH in the last maybe 5-6 decades. But if you see here, 1947, it was discovered as a factor influencing male differentiation. Nothing much thereafter, because okay, now we know that how males are being formed rather than default getting into a default mode of female. So everybody said, okay, there ends the role. Now, the Viger et al. In 1984 were the first ones to say AMH is also looked at or being produced in the adult ovary. Again, some data started coming up about the ovarian function and other things. And in 2002, the first paper which showed that AMH actually correlated with the ovarian reserve. And there is an exponential rise of looking at AMH. We had better standardized assays thereafter. And all sorts of ovarian functions are being assessed as far as linking it up with the AMH is concerned. So now you can see the graph is going up and in a completely different manner than the initial almost 4-5 decades of the AMH existence. What is the physiology? Both in males and females, it's secreted by the Sertoli cell and acts through AMH receptor type 2 commonly, and the basic role is just inhibition of the Mullerian structures. Now, there is some local paracrine relation with the Leydig cells because the testosterone is actually an inhibitor of the AMH as a paracrine role, but directly it doesn't affect the any development of the other axis and not the functioning of the Leydig cell. In the females, the basic role of AMH is to actually select the appropriate follicle for the ovulation. So it prevents that FSH stimulated growth, so that let one follicle develop rather than get multiple things come and get follicular arrest, inhibits the granular cell growth and inhibits the aromatase. So this is where actually the function of it is there, which possibly is being looked at in multiple angles as the study is evolving with the use of AMH in different spectrum. This slide is a bit important only because I will be referring to these values most of my talk, especially when I talk about DSD or other places. If you look at the age-related changes in the AMH, the males obviously secrete far higher than when compared with the females. Initially at birth, the female value is very minuscule, starts rising just prior to puberty and peaks at about 20-25 and then gradual decline commensurating with the declining in the estrogen function, ovarian function. Whereas if you look at the units here, it is 0, 25 and 50 picomoles, whereas in males it is 500, 1000 and 1500 picomole. And look at the value. This is all postnatal. Now postnatal, so much AMH in a male actually, what does it do? I mean, we don't have a definite answer to it as yet. I will tell some of the things, but you have a hormone which is being secreted at so higher level without having a function is a very surprising thing. So we are yet to understand the entire functioning or entire physiology of AMH in that perspective. But the values are quite high in the males than when compared with the females, and they're more in the initial ones. And mind you, these are not affected by the mini puberty. These are not affected by your testosterone surge, LHFSH, anything like that. It is just a normal variation of the AMH. So where exactly AMH fits in initially, the smallest or the easiest role with which it was identified was determining the male sex, then possibly looked at as the ovarian follicular growth, and then possibly ovarian reserve, and then assessment of it and associated functioning or evaluation in the most of the reproductive endocrinology. And then further, now last decade, there was GnRH neurons have been shown to have AMH receptors. There are a lot of neural effects of the AMH, which may determine the GnRH pulse, priming, puberty, PCOS. There are a lot of research going on here. So from what a simple looking determination of male, now we have actually looked at, you are actually determining a lot of other things even at the hypothalamic pituitary axis. So that's how the journey of AMH over the last 5-6 decades. So we will initially spend some time about the reproductive endocrinology, and then we go to the others as the seminar progresses. Across the spectrum of the females, the basic thing what ovarian reserve, which it has been studied, is the robust marker as far as the ovarian reserve estimation. Now that is important because especially when you are assessing the fertility potential, or when you are assessing somebody who has got recurrent abortions, why all those things. Conventionally, what you do for estimating the ovarian reserve, maybe a FSH day 3 more than 10, that indicates that there is a reduced reserve. The FSH obviously will give you a clue that your ovary is not functioning. Maybe along with inhibin B will give you a more clue along with estradiol, ovarian volume measurement, and somebody said ovarian antral follicle. But all of them have got some subjective variability and not very easily doable tests. So then came the AMH, which actually is secreted by the follicles, and most of the early antral follicles will secrete it. And the biggest advantage of it is the no cyclical variation, because if you have to do a FSH, if you have to do LH, if you have to do estradiol, you have to know at what phase of the menstrual cycle the lady is, and look at the graph of the AMH levels across the menstrual cycle. It is almost at this flattish level, irrespective of the menstrual cycle phase. Your AMH is going to be at the same level throughout whatever of that particular individual. So that is where it is important that you have a marker which you can just randomly pick up and do, and then give or get a clue about your ovarian reserve. So that's important, and which has actually helped a lot of practitioners, a lot of researchers to circumvent and maybe look at, not look at the FSH at all in the clinical practice as a marker for ovarian reserve. This is where what I have said about the production of the AMH. The early small antral follicles are the ones which starts producing, and that is the where your AMH expression is the maximum, and it reduces as it goes into the pre-ovulatory phase. Now, once it is a marker of ovarian reserve is well established, that will automatically translate to a marker of a premature ovarian insufficiency, because any failure of ovary, your AMH has to go down. There is no doubt about it. So how early? That far early than when compared with the negative feedback for FSH to rise. So it's possibly a bit early marker than when compared with the rise in the FSH. And this also can predict the transientness or the permanentness of the POI. In the sense, suppose somebody who has got a insult, maybe because of the drug, maybe because of the radiation, some other issues. So you can actually predict whether this ovary is likely to recur or likely to regain its function or not. The same thing as a marker of ovarian reserve is applicable in the post-chemo, post-radiotherapy. Whoever, especially in all these genitourinary malignancies, especially in ladies who have not yet finished their families, it's important to have this as a marker, because you wouldn't be looking at using drugs which have high ovarian toxicity. For example, cyclophosphamide, melphalan, they have high ovarian toxicity. Depending on the underlying malignancy, you can choose some of them which are beneficial or which are of less toxic to the ovary. So this is where, as extension to ovarian reserve, it will further help us in finding out to identify drugs which are better or which are less impacting the ovary, and which as a marker of the POA also will help in where you are actually getting the maximum benefit, where you are likely to give the drug early or not. Another major place where the AMH is in the PCOS. It is like phenomenal number of studies where it is actually likely to be a more robust diagnostic marker than one of the ultrasound based criteria of identifying so many number of follicles, so many size, both sides, stromal size, itna volume size, so ovarian volume, all those things. Most of them are subjective. And why it is important, if you look at the early secondaries, early antral follicles, the antral follicle, these are the ones which actually are the ones which secrete the AMH. Now, all of them will contribute for the AMH level, whereas only these are the ones which are picked up by the ultrasound. So it's important to know any vascularized tissue, then irrespective of the size of the follicle, whether it is being picked up in the ultrasound or not, the AMH level will correlate. The AMH will contribute. So some studies have said that AMH more than 5 will correlate with hyperandrogenism and may be useful as an additional diagnostic marker in PCOS. And second important thing, it does help in whenever you're trying to use ovulation inducers, it does help in predicting the response. And maybe you have high AMH in the start, it does predict your risk of the ovarian hyperstimulation. So it's important to know that the baseline AMH will give you as to what is the ideal drug to choose and what are the likely risk of complications, all those things. So that much of information you will get by a simple hormone. Ovulatory dysfunction as per WHO is classified into type 1, 2 and 3. The basic thing, type 1 is like a hypo, where the AMH can be either normal, low or elevated. The type 2 is the common garden, the PCOD, which the AMH is elevated, and type 3 is like your POF. It's a hypergonadotropic hypoestrogenic, so where your AMH would be low. So in a normal evaluation of any anovulatory disorders, if you just do a AMH, possibly type 2 and 3, you can easily pick them up without resorting to more tests. So a single test will possibly help you in identifying what sort of ovulatory dysfunction the patient has got. Coming to the fertility and assisted reproduction areas. Now, AMH is basically because of the follicle and because of the development of follicle and then the oocyte. So the oocyte quality is one of the major thing which is determined by the age of the patient, and the quantity, how many will come out, how many you can actually retrieve, is by the AMH, which will give you a prediction that you are likely to have this many number of oocyte yield if you use a ovulation inducer or if you use HCG. So some of these things will help you in planning your ART therapies. Another important thing, it may serve as fertility test before marriage. It is like you have a good AMH, so you are likely to have a better fertility potential, indirect way of assessing your ovarian reserve. And OHSS, I've already said, if you have an excessive response to FSH, may be there. If your baseline AMH may be more than 3. And if your AMH baseline is less than 1, the response to FSH cannot be good. So look at the AMH level and then decide the dose of FSH when you are doing these ART protocols. The general, what do you call, guideline or maybe the advice or prediction to the patients, Depending on the AMH and age, if the patient's age is less than 38 and AMH is more than 3, ideal case scenario. But only thing, just be worry about the risk of OHSS. And if age is less than 38, 1 to 2.9, again, it's not very high AMH, and possibly you can get the best possible outcome. Age less than 38 and AMH low may require more cycles. So you can prognosticate the patient when they are going for IVF that, look, this is how your profile is. This is how your likely outcomes are. So don't expect that even at the end of first cycle of oocyte retrieval, you're unlikely to fertilize or you're likely to have the positive outcome. So that is important to educate the patient. Age more than 30 years, AMH more than 3, very unlikely to happen except for some of the tumors or issues. But possibly that will give a clue that you have a better outcomes. And if suppose AMH is less than 1 and age is more than 38, you should be able to counsel the couple or the lady that look for some other option rather than go for IVF, maybe adopt or some other thing, because these are the things which will give you a clue as to how to deal with the patient in the clinic. The last in the reproductive endocrinology pertaining to the females, the most important thing is the menopause, where you're likely to have. So as I said, the AMH at a threshold can actually predict 5 years prior your likelihood of going into menopause. So there are beautiful studies which have followed up the patients with their baseline AMH levels and then looked at that this is the one which is going to go down the first, and then possibly will help you in preparing the patient for the menopause, especially for somebody who has early menopause or somebody who has symptoms of menopause. So it's important, if you find a maybe in mid 30s or late 30s a lady with a minuscule AMH of maybe 0.6 or 1.2, you should be actually able to counsel that your likely course of menstrual cycle is like this. So maybe you would require a HRT for some time. So prior preparation and priming the patient will actually help when the actual event happens, and then possibly they don't have to bear the burden of those menopausal symptoms more. So it's actually helps as a predictor of menopause also. So much about the female reproductive system and female fertility, but male fertility is not lagging so much behind, but there is some lag definitely. Postnatally, if there is any definite role for AMH, it is not yet there. So that is, their AMH receptor knockout models have been studied, which have looked at any functioning affecting the testicular function or maybe sperm quality, mild changes here and there, but not a very significant, remarkable effect. But it does tell us that since it's being produced from Sertoli cell, that it's a marker of Sertoli cell function. Now, some studies have started coming up, whether looking at using this AMH in some disorders of male infertility, and then maybe extrapolate that in their clinical practice, how best to use this as a marker in deciding about the course of management. Maybe for a male PCOS, male equivalent of a PCOS, which either only androgenic alopecia was considered, the AMH level also may get added. And DD between anorchidism and cryptorchidism I'll deal with in the DSD. Now these are different male infertility disorders which have different AMH levels. Like pubertal delay, you have normal prepubertal level. Congenital hypoapo, you have decreased AMH in the puberty. Klinefelter, maybe puberty related decline later on. McCune-Albright, macroorchidism, increased AMH level. Varicocele, some variation in the data, but as I said, these are more evolving. Not, I mean, all studies are like those 20s and 30s number, not a big scale and not much definite effect. Paper which was published in Nature Scientific Reports last year. One of the interesting thing which they said that if you have non-obstructive azoospermia, the only option was about doing TC or micro TC, and procedure itself is cumbersome, costly. So they said can we circumvent or can we pre-screen the patients and then identify a better biochemical way of identifying that who are going to benefit if you do for a sperm extraction. So about 70 odd patients they have studied, and they given a cutoff of AMH more than 4.6 will likely to lead to a poor surgical outcome. So you're not going to get anything, which in turn indicate that it's a depleted germ cell reservoir. So elevated AMH or AMH, they have looked at AMH and total testosterone ratio also. So some of these are importantly being looked at in the male infertility as well. But as I said, there are very small number of studies. But since the residents are there, some of you can actually look at some of, depending on the number of patients, you can easily start doing some of these studies, which will be a good information in the field of this AMH in male infertility. Pediatric endocrinology, there is again huge data about AMH. The basic role, since it is being produced from the testicular tissue, from the Sertoli cells, it only indicates that there is a presence of testicular tissue. Now, you have simple virilization in a female. If there is AMH is like a female, it's like a common garden CH. But if you have a AMH which is quite high, that straight away puts the ball in the courts of dysgenetic testes or ovotesticular DSD, something like. So look at this simple marker, which will straight away change the how you approach the patient. The constitutional delay and IHH, there are no robust markers to differentiate between the two, but AMH also is considered to be one of the marker, where because of the exposure of AMH and irrespective of the AMH being produced normally, it will be normal in constitutional delay, whereas it will be low in the IHH. Completeness of surgical removal in ovotestis, that will help, because any testicular tissue, as I have shown, the levels are markedly elevated in males than when compared with the females. So any detection even of 10, 20, 30, that indicates that there is a incomplete removal of ovotestis. Varicocele inconsistent data, so we will leave it. Now, this is a chart which is a bit confusing, but I'll just go slowly on this. 46 XY DSD, simple. You have testo not present or AMH not present, so both are not being present. So it's complete the typical Swyer syndrome, that is complete gonadal dysgenesis, because XY DSD and you have low testo and low AMH. But you look at this XY DSD, you have low testo, but AMH is like a normal male. So AMH being Sertoli and testo being Leydig cell, you have only the Leydig cell specific dysfunction. So in the relation between testo and AMH in a DSD can help you in identifying the underlying disorder easily. Testo is normal, but AMH is less than what it is supposed to be. So it's like a Sertoli cell specific dysfunction. So that is also important. Testo normal and AMH normal, so you have defects which are further down below, that is the androgen insensitivity or phi alpha reductase. So depending on the levels of testo and AMH, the relation between the two, you can actually look at where the person is going to as far as the underlying condition is concerned in the DSD. XX DSD, testo is more than what is supposed to be in a female, but AMH is normal. So testo, obviously you find that ovarian or adrenal is the only source. So it's a adrenal one, which is likely to cause, common being CH. Now, XX DSD, testo is in the range of male and AMH is in the range of male. A simple testicular DSD. Somewhere in between these two, that is like not at that much high values or not typically normal values, you have ovotesticular DSD. So you can have a spectrum of DSDs identified by a simple AMH and testosterone values and look at the comparisons in the relevant normative of that particular age. Androgen insensitivity versus phi alpha, there is some differentiation, even though both of them fall here, that is testo male and AMH in the male range. but AMH is in the lower range of normal, whereas in the androgen insensitivity, AMH is very high because the paracrine inhibition of testosterone is lacking here, whereas in the 5-alpha reductase, it is only the DHT which is lacking, but testosterone is very well present, so it's in the lower range of normal. Now, cryptorchidism, you just do a AMH, you know that there is a testis inside. May not require the HCG test, which is more laborious, more issues, and more possibly standardized situation is a bit issue. Phenotypic male with absent testis, the AMH will give you some clue about what is the diagnosis. If it's low AMH, as what I've said earlier, dysgenesis, CAH, or NRPA. Or if it's a normal AMH, it is cryptorchidism, or AMH or gene mutation. This is one place where you may have a normal AMH, but you may not have the underlying testis. So another important thing at this point of time is, whenever you look at absent testis, was it absent right from day one, or was it anarchia later on? So you need to rule out, do a ultrasound or MRI to see the Mullerian structures, because some patients are there from 4th month intranatal life, 5th month, there is testicular anarchia happens, but they don't have the Mullerian structure. So you know the onset of anarchia based on the presence or absence of the Mullerian structures. In the persistent Mullerian duct syndrome, if you have undetectable AMH, it is simple AMH gene mutation. But if you have normal AMH and undetectable inhibin, it's a AMHR gene mutation. So you have a clinical profile of PMDS. So AMH absent, so you know where the problem is. It is at the resistance at the gene. But if it's normal AMH, the gene mutation which doesn't let it act. So you can easily identify at a given level, at a given, along with the other parameters, where exactly is the spectrum of involvement. Pubertal disorders is one place where there is not much of studies at all, actually, because especially in females, the values are very minuscule in that level. And in males, they are very high, but not much of role as far as anything, as far as either precociity or delayed. As I've said, premature thelarchy slightly higher than when compared with central precocious puberty. But these are like a small number of studies, so I wouldn't say much about them. Look at DSD and their clinical sign and the AMH. So cryptorchidism, you may have undetectable AMH in anarchidism, or if it's normal, you rule out AMHR mutation or rule out testicular dysgenesis. Micropenis, AMH may be undetectable if there is a fetal testicular regression, and absence of puberty, again regression, or if it's normal, you look at CDG. Precocious puberty signs, if you have normal AMH, you look at CAH, and if it is low, it's a true central precocious puberty or testotoxicosis. So DSD we've already discussed. So based on the presentation of the patient, the AMH level can lead you into a possible direction of clue towards the clinical diagnosis. Another interesting thing area which most of the researchers have now focused is about the GnRH AMH receptors. Now GnRH neurons have been shown to have the AMH receptors, and there is basically, it stimulates the GnRH pulses. And whenever the pulsatility in GnRH goes up, your LH goes up. And if your LH goes up, the androgen production goes up. And this is where some of the issues are coming up, that is the PCOS more neurologically also mediated through AMH rather than a just simple marker at the follicular level. So lot of studies are coming up at this level about neuroendocrine role of AMH, and some of it is applicable because we all know that PCOS mothers have higher risk of PCOS daughters or like that in families. Now there is more data to suggest that the transgenerational programming happens because of the AMH. It inhibits the placental aromatase, which increases the androgen viability. higher androgen levels, in utero exposure, so GnRH neurons are primed accordingly, and more AMH later on in the mother, which increases the GnRH, which increases the LH-driven ovarian androgen. So there is some data to suggest that the PCOS is not only the environment, there is some genetic, there is some transgenerational effects also. The prenatal programming of PCOS also happens. So AMH in the pathogenesis of PCOS, there is multiple levels at which it acts. Simple at the level of the ovarian level, it inhibits the initial follicular recruitment and arrests the follicle. So that is where at the level of the ovary. But AMH on the GnRH neurons, it increases the LH pulse and LH-FSH ratio, and there is rather affects the intrauterine fetus and expose them to a more androgen level. So at multiple levels, AMH effect leading to the PCOS as an adult. So we can think that it's not only a diagnostic marker, but even a pathogenetic marker as far as the PCOS is concerned. Very high AMH levels are only seen in two conditions: ovarian hypertrichosis and granulosa cell tumors. Now, granulosa cell tumors, it's a robust tumor marker because that is where it is being produced from in the ovary. So elevated AMH may precede the tumor quite early, and it has direct correlation with the tumor size, predicts recurrence and success of ovarian transplantation also, because it's a very good tumor marker in GCT of ovary. The only issue of AMH, why it has not taken so much potential as what it otherwise would have, is first point is that individual variability is more than 100-fold. Now, if you, I mean, obviously we all should have the population data, but individually you have what is known as the genetic variation in the primordial follicular pool of each lady. So unless you have that normative data across possibly the racial, across possibly regional variations, you may not actually extrapolate this data across board. So if AMH say less than 1 indicates subfertility, may not be true for everybody, or maybe less than 5 may be subfertility for somebody, whereas it is high for somebody. So that we need to understand. So that is why it is not yet reached to the potential where it actually is. And second important thing, it predicts a lot of things: the fertilization success, blaxulation success, miscarriage rates also. But the only gold standard marker whenever you do any interventional study in the assisted reproduction is the live birth rates. AMH doesn't predict the live birth rate. So none of the studies have been able to show that this is a good marker to predict live birth rates. So that is where again, it's a hard endpoint. So that has not been successful. And standardization in the essay is an issue, and ethnic variability is an issue as far as looking at AMH as a marker for all these what I have said. The factors affecting AMH levels: elevated, obviously PCOS. Important thing, vitamin D deficiency and summer months. There is a 20% variation in summer and winters, and racial variation is significantly there in the available number of studies. The Chinese have got more level of AMH rather than blacks and Hispanics. And only other important thing beyond ovarian surgery and chemotherapy, etc., the use of OC pills, you may have low AMH because estradiol inhibits the AMH. So whenever you are looking at AMH in a lady, please take the history of OC pills and any carriers of the BRCA1 and 2 mutation. That is also important. Going by the places where it actually can affect and multiple places. So AMH analogues are being developed in the reproductive medicine, but as I said, they have not even reached a phase 1 or phase 2 studies, but a lot of research is going on in the animal levels that you may have AMH agonists in future, which possibly will help in fertility preservation because you're actually looking at delaying the onset of menopause. You're preventing the recruitment of early follicles, and it may act as a contraceptives. And some of these were more estradiol dependent cancers that will help in reducing the level and will help in the management of endometriosis also. So AMH agonists are possibly considered to be used at that level, and AMH antagonists are being tried in as an ovulation inducers because the arrested follicle is let it go. So that helps in possibly more maturation and then ovulation induction. So in a nutshell, if you look at the different areas from birth to adulthood, in the birth to childhood about the DSD, and in pre-puberty maybe differentiation between the CDGP and IHH, and adulthood most of the reproductive endocrinology functions well and AMH in the endocrine practice. But the definite ones, there is no doubt most of the people agree that ovarian reserve estimation, AMH is a very good tool, so there is no controversy there. Probably PCOS will come maybe in a couple of, maybe not years, maybe at least 5 to 6 years. It will come as one of the diagnostic markers for PCOS. DSD, it has pretty long data, pretty much good data, but the number of DSDs are less, so it won't reach to a certain level where, because of these assay variabilities, prediction of menopause, definitely it has some role in pubertal disorders, ART protocols, and in tumors. And futuristic role is there only in AMH analogues. At some place it will come, because as I said, there is n number of places AMH acts, so we don't know where all we can actually use them in the clinical practice. This is a lady who actually done tremendous work in the AMH, Professor Josso from France, student of Professor Alfred Joss. And if anybody wants, just read this article in Reproduction. This was basically Women in Reproductive Science. This is an article. She has just given her how she ventured into this research right from her early days. It's a, I mean, beautiful tribute, and actually it's an insight to know that how you get after a topic and then learn and then explore further. Because Professor Joss said 1947 there is something known as Mullerian inhibiting substance, but it took almost 30-35 years before people could lay hands on AMH. So it's a journey, it's worth reading. I have finished here. I shall be happy to take any questions.
Thank you, Dr. Harikumar, for your excellent lecture on this topic. So really, we are grateful to you. And of course, our residents will be of immensely helpful from your lecture. Now, the session is now open to discussion. So residents or other colleagues or faculties may now interact with Dr. Harikumar. Yes. Hello.
Professor Sahana.
Yes. Yes, sir.
Thank you for arranging such a very fascinating and exciting lecture. So many facets of, the AMH, either to unknown to us, have been beautifully elucidated, and a lot of data, and it's very stimulating talk. It's just one simple question: how vitamin D is related with the AMH, and whether the AMH has any data with the leptin levels or not.
The vitamin D deficiency actually is one of the falsely elevates the AMH. There is enough data. In fact, there is a meta-analysis published in the endocrine practice a couple of years back. So vitamin D deficiency, there is definite link. But leptin, I am not sure. I have not come across any relation with the leptin and AMH. I am not aware of anything.
Because leptin has some effect on the GnRH neuron. So that's why I was just wondering whether it has got any correlation with the, the AMH, because as we have shed light on the recent very exciting passage, the neuroendocrine GnRH. So these things are very interesting. I think in future we'll be in a position to correlate the leptin generate an AMH. Thank you, Professor Harikumar.
Thank you, sir. Only, yeah, as I said before, it's actually the so much of AMH is being secreted in males, and we still don't know what it is going to do. And it has actually not helped us reach anywhere. That is where the problem lies. I mean, prenatally, yes, it has definite role. But postnatally, if it has no role, why Sertoli cells keep on secreting so much AMH?
Right. So how do you think? So is there any acceptable or international guideline regarding any standardized cutoff level of AMH in diagnosis of PCOS?
So more than 5 is what is proposed. There is no guideline which has not reached the guideline, but multiple studies have said that if you keep the 5 nanograms per ml as the cutoff, you are likely to circumvent the need of doing an ultrasound, because ultrasound has a lot of subjectivity. So that is what I've said. But it has not been part of guidelines. Some of the gynecological societies are not keen to do it. 2 reasons. One, the AMH standardization is a bit question mark about it, and possibly, since it has not been shown to be of direct correlation with every other, it has been shown to only about the hyperandrogenism link, but nothing else. So that is where they have not yet agreed that it is a marker for PCOS, but it will come up in some years to come when more data emerges about it.
Thank you very much. Any question? Professor Sengupta, please.
Yeah, Dr. Harikumar, thank you for your very interesting talk. Now, as you said, there is a gender dichotomy or sexual dichotomy in the levels of AMH. It's more normative values are more in males as compared to females. Is there any intradian or ultradian differences pulsatility? Because Sertoli cells would be secreting AMH in a continuous manner, but just as the gonadotropins, they have a relationship with the menstrual cycle. Is there any such thing suggested for AMH, depending on the AMH levels, depend on the menstrual cycle? Because with the recruitment of the follicles, has anybody looked into it that way?
Okay, you mean to say the reverse of it, rather follicles are getting recruited and AMH is going up in a relative terms, but vice versa you're asking. See, in a normal course of, that is why in the menstrual phases, there are plenty of studies where they have said that there is no phasic variation of the AMH level, because there are 2 things here. AMH is positively regulated by your FSH, negatively regulated by testosterone stroke estradiol. So, but those are the 2 things which will, and some of the times one overtakes the other, and then will not give you a clear-cut level which you can bank on. That is where possibly I feel it has not reached a good level or a good marker level. If both of them are going to act simultaneously to have an independent action of a particular hormone over the AMH is unlikely to be beneficial. So that is why when I said about testosterone, it is the paracrine role which has more role rather than the systemic testosterone. So it inhibits more at the level of testis. Local production makes more sense rather than coming up from exogenous ones. So that is where it has a lot of difference as far as the interpretation is concerned.
Thank you. Yeah, that's. And Pankaj Singhani has a question. Pranab, you can take that. I think Pankaj has asked a question.
Yes.
How to interpret AMH more than 23? We get this report commonly in evaluating DSD. So now, I mean, what DSD number 1? XY or XX?
XY DSD, sir.
So XY DSD, so AMH is a bit reasonably on the higher side. reasonably, I would say. It's not very high if you're looking at XY, because as I said, XY, you have a very high levels of AMH. Okay, what about the testo?
Actually, this situation arises whenever we are trying to deal with XY DSDs. Before we go on doing along with the basal hormonal tests, androgens, and a plan for the HCG stimulation, we do a basal AMH report to exclude gonadal dysgenesis. So generally we get the report as more than 23. And when we asked for dilution in one of the laboratories, they said that only permissible dilution is 1:1. They gave us the report of more than 46. So is this enough to exclude gonadal dysgenesis? Because we don't have an upper limit. It is just saying more than 23 or more than 46.
See, yeah, in a sense, in a elevated AMH, you will not have much benefit as far as excluding or identifying. I mean, unless in the relation of testosterone, you will not get any clue about how to maybe go about things. It's only, see, as I said, the AMH in males, it's in hundreds to thousands. Okay. So there you are actually, I mean, if it is more than 23 or 46, it doesn't help you much. If you have a low testosterone, it does help a lot.
All right. Thank you, sir. Thanks.
Any other questions from anyone?
Professor Harikumar,
Sir,
you just enlightened us that it is one of the surrogate marker of impending menopause. Okay.
correct.
So, and it will be of great help in preparing the patient mentally and also in other way for the menopause also. Now, after the menopause, when we contemplate HRT therapy, if there is no contraindication, in that perspective, whether the AMH level monitoring will be of any help, whether the HRT levels are getting some beneficiary effect or doing some harms. So this is an area which must be very much transparent and clear, because we'll have to tell the patients that I am contemplated to introduce HRT, so you will be benefited, or some groups that you will not be benefited. So this is some sort of controversy, contradiction, etc. So let me know from erudite person like you, what is your take on this?
See, I mean, menopausal stages are that straw staging of menopause is the one where you actually look at the menopause, and definition is very clear. Now, the symptoms can occur before, during, or after also. Now, what AMH actually tells you is the likelihood of reaching a, say, early menopause. I mean, most of the guidelines now are very clear. If you have early menopause that is below 45, you should be giving them any symptomatic therapy. Without any fail, the HRT is indicated without any problem. Now, instead of actually waiting at that point of time and then possibly let the patient maybe suffer, or maybe have some doubts about HRT, if you just prime the patient, say maybe at 35, 38, or you're likely to have a early stoppage of your menses, if required, we shall start you a pill at that point of time. That would actually ease up a lot of apprehension about using a HRT in the practice. I mean, it's like, say, using a insulin at the initial outset itself. Patient will not have, when A1C goes 15, why should you use insulin? If you use it 8 or 9, he will be happy, and that is easily. So that will help us in identifying who is likely to have a early menopause and prime the patient for using the drug.
Thank you. Thank you for this valuable input. Thank you, Professor Kumar. A big thank you.
Thank you, sir.
So with this, if there are no questions, so once again, I thank you, Dr. Harikumar, for your excellent talk and discussion. So may I now hand over to Professor Sengupta or our resident Yashaswi.
Thank you, sir.
Thanks, Dr. Harikumar, and thanks, Dr. Pranab Sahana, for sparing your valuable time. Over to Yashaswi for the concluding remarks.
Thank you so much, Harikumar sir, for such an exhaustive talk on this very important topic. And thank you, Sahana sir, for giving your valuable time for chairing the session. Before I conclude today's talk, a note on the next 4E webinar. I just share my screen once. So the topic for the next 4E webinar, which is going to be on the 1st of April, is time-restricted eating from theory to practice, a critical appraisal. This webinar will be chaired by Dr. Jubin Jacob sir, and the speaker for this webinar is Dr. Rahul Valsaraj sir. With this, I conclude today's session. Thank you everyone for joining, and we hope you join us for the next webinar as well.
A big thank you, Professor Sengupta, you being the prime mover of such wonderful academic feat.
Thank you, Professor Vasu.
Yes, thank you, Professor Sengupta, for inviting me to this topic. Thank you.
Thank you, sir. Thank you, Professor Sengupta and team ESB. It's a great honor and pleasure to be here. Thank you.
Thanks. Stay safe. Meet you
Same.
with all of you at Crescendo, probably physically or in some other conferences. Thank you.
Sure, sir. Sure.
Thank you, everyone. Thank you.
Bye.
Bye.